Hello, everybody, and welcome to the Society for Advanced Bronchoscopy Fellows Corner once again. I have the honor of once again presenting one of my esteemed fellows here, a first-year fellow, soon to be a second year in a matter of weeks, Joshua Wortsman, who's here to talk about a very interesting case on mesothelioma diagnosis when cytology falls short and MT or medical thoracoscopy was needed. Joshua is a wonderful fellow we have in our pulmonary program here, which is with the joint with the Rosalind Franklin University of Medicine and Sciences and the North Chicago VA Hospital. Josh did his medical school in Tel Aviv, Israel, and followed by his internal medicine residency at Sinai Hospital in Chicago. Your host here, Hasnain Bawaadam, the Associate Program Director for Josh's Fellow and Education Committee member with the Society for Advanced Bronchoscopy. Over to you, Josh, and good luck.
All right. Hello, everybody. Thank you for joining in. So the title of my presentation is called When Cytology Falls Short, the Role of Thoracoscopy in Diagnosing Pleural Malignancy. Again, my title. So we're going to be discussing this patient initially. She's a 65-year-old female. She's got a past medical history, which includes a lung nodule. She's got a family history positive for cancer. And she's a former smoker, quit in 2016, but had a 40-pack here. She's got no known toxic exposures in her history. She was previously involved in her military service and was living on a naval base in the 1990s. And she underwent a robotic bronchoscopy in 2023 for a 14-millimeter solid nodule, which showed benign endobronchial and alveolar tissue. So she presented to the emergency room in our hospital. She basically presented with shortness of breath, and CTHS demonstrated this large pleural effusion, which completely collapsed the right lower lobe and partial collapse of the right middle lobe. So this is the video of that CT, and as you can see, she's got a sizable right side of pleural effusion. Thoracentesis was performed and they removed 1,100 milliliters of fluid, which turned out to be exudative. So here's the fluid analysis, which, as you could see, is an exudative fluid analysis. And she had a cell count which was elevated with lymphocytic predominant. So cytology returned negative, was positive for atypical cells that favor reactive mesothelial cells. And a little word about reactive mesothelial cells, as you can see in the corner of my presentation here. These are basically hypertrophied or hyperplastic cells. They are hypertrophied or hyperplastic cells, mesothelial cells that react in a pathological environment, be that trauma or infection or inflammation or neoplasm, but they themselves are not neoplastic. And this is basically what they found. And so in summary, we have an exudative fluid of unclear etiology. So 2 additional thoracenteses were performed, and these thoracenteses removed 1,600 milliliters of exudative fluid on the first one and 1,800 milliliters of exudative fluid on the second one. So in summary, basically, we had 3 thoracenteses performed, negative cytology for all of them, atypical lymphocytic exudate for all of them, and the evidence of reactive mesothelial cells. And after they removed the 1,800 milliliters of fluid, we performed a CT scan on our patient to see what the lung looked like after removing all that fluid. And this is the CT scan. As you can see, after removing the fluid, there's more evidence of pleural thickening around the lung and studding. And so that's it in an axial view and in a coronal view. And in case you weren't able to visualize those well because of the speed and the quality of the video, I have it here in stills. So on the left, you can see the axial still, and on the right, the coronal. And you can see that this patient has pleural thickening, also in the fissure along the right lung. So what is it that we did after this point? That we have thoracenteses that return negative? Well, the next stage, the next step would be to perform a medical thoracoscopy. So this is the medical thoracoscopy, which is actually performed here at the Royal Medical Center in Kenosha. And this is our staff performing it. And this in the left is an image of the pleural thickening pleural mass that we were able to remove during the thoracoscopy and send for samples to the pathology lab. And so what is it returned of? Oh, sorry. This is a video of the thoracoscopy, not on our patient, but this is a video of thoracoscopy that I found on the internet attributable to this website down here, just to give everybody an idea of what it looks like. And so you're able to directly visualize the pleura, and you can take a sample directly after visualizing it and knowing definitively that you're sending a good quality sample over to the pathology lab. So our biopsy resulted as epithelioid malignant mesothelioma, and now I want to have a discussion about malignant mesothelioma. So malignant pleural mesothelioma, basically on the left-hand side there, you could see a normal lung. On the right-hand side, you could see a lung which has, or a diagram of a lung which has malignant mesothelioma, which starts as pleural thickening. It could be discrete areas of pleural thickening, which then coalesces into a rind-like mass around the lung. It predominantly starts on the parietal pleura, but as it advances, it could also start to encase the visceral pleura as well. So malignant mesothelioma, here's a gross sample in the bottom right corner. It is a universally fatal malignancy. It typically affects the pleural cavity, but may also present in the peritoneum, pericardium, or tunica vaginalis, and the majority of cases result from asbestos exposure. So clinical features in general, it typically presents 20 to 40 years following first asbestos exposure. Average age would be of diagnosis is in the 70s. 80% of patients are male, reflecting demographics of workers in at-risk occupations like pipe fitters, brake liners, construction workers. And most present with pleural effusion, but patients will also commonly present with breathlessness, cough, chest pain, constitutional symptoms. And about 20% of patients have no history of exposure, even after detailed assessment. And that is true for our patient. I mentioned before that she was previously in a naval base in the 90s, which is a possible exposure, but she didn't have any clear definitive exposure on thorough history taking after evaluating her. So I briefly want to talk about mesothelin. Mesothelin is a biomarker. As we know, biomarkers are biological molecules or processes which are used in the diagnosis and progression or response to treatment in malignancies. Mesothelin is the only biomarker which has been approved by the FDA for the diagnosis of, or the diagnostic workup of malignant mesothelioma. And here we can see a literature review presented at Frontiers of Oncology in 2023, which evaluated 16 different papers, more than 4,000 patients in total, to determine the sensitivity and specificity of mesothelin as a biomarker. And what you can see here is that it's got a relatively high specificity, in the 90 to 100% range, whereas the sensitivity is a little bit more distributed all over the map, and it is less sensitive, somewhere in the 50 to 70% range. And so when mesothelin is used as a biomarker and it presents positive, then it gives you a indication that you're on the right track and you should continue with your diagnostic workup. Its use as a biomarker is limited because of its poor sensitivity. So if it is negative in workup, then it doesn't give you a clear indication of whether the patient does or does not have malignant mesothelioma. So mesothelin as a biomarker is a glycoprotein expressed on the surface of mesothelial cells and is overexpressed in mesothelioma. And as I mentioned, it's the only biomarker approved for malignant mesothelioma by the FDA. It's worth noting that it's renally excreted. And so in patients with renal impairment, it could be elevated, which could affect one's interpretation in understanding whether this patient has a false positive elevated mesothelin. And so it can be collected from the serum or the pleural fluid. And an elevated mesothelin strongly suggests mesothelioma, but a negative mesothelin test does not exclude mesothelioma. And in terms of its sensitivity and specificity, it's more sensitive when it's retrieved from the pleural fluid, 70 to low 70 to high 70 range, as opposed to the serum, where it's got a broad range of sensitivity, somewhere between 20 and 70%. In both the serum and the pleural fluid, it is found to be quite specific. Additional biogenetic markers, I briefly want to talk about BAP1 loss immunostaining, which is BRCA-associated protein 1 loss immunostaining, which is a tumor suppressor gene. And when it's absent, it's an indication that this patient might have malignant mesothelioma. It is quite specific and somewhat sensitive in the 60 to 70% range. And CDKN2A, which is also a tumor suppressor gene, when it has a homozygous deletion evaluated on fish, fluorescence in situ hybridization, it's also an effective biomarker for mesothelioma. These two are not FDA approved, but they're frequently used. And when used in tandem, they give you a strong indication that you may diagnose your patient with malignant mesothelioma. In terms of histological subtypes, it can be epithelioid, which is the most common subtype. It also has the best prognosis in about 60% of patients, sarcomatoid in 20%, and biphasic in 20%. Epithelioid, as you can see here, it has these polygonal epithelial-like cells. The sarcomatoid has more of spindle-shaped cells, and the biphasic histopathological sample will have a combination of both. In terms of radiographic findings, the most common presentation is pleural fusions. Although no distinguishing features reliably differentiate mesothelioma from other pleural malignancies. And as mesothelioma progresses, as I mentioned before, it could start off as discrete pleural masses or pleural studs, which can then encapsulate the lung and coalesce together, which can contract the hemithorax. And this leads to frozen mediastinum sign, and in frozen mediastinum sign, in a normal mediastinum, when there is pleural fluid or a pneumothorax on one side of the chest cavity, then it will push the mediastinum over to the contralateral side of the chest cavity. And frozen mediastinum sign, because the mediastinum and the lung are ipsilaterally or even contralaterally, but ipsilaterally encased, let's say with malignant mesothelioma, then it's going to keep it in place. It's not going to push it to the contralateral side, and that's indicated as the frozen mediastinum sign. So here's radiographic findings. Again, the most common radiographic findings are going to be pleural fusions and pleural plaques. And here on the CT, you could see on the CT on the left in the coronal and sagittal sections, you can see that the plaques are going along the fissures. And on the CT on the right in the chest X-ray, you can see these pleural plaques going and encasing the lung on the parietal pleurum. So biopsies. Needle tract metastases are common with mesothelioma, which is one needs to be aware of when performing biopsies. There is a study, one reported study indicated that seeding incidence occurs in 22% of surgical biopsies, both with thoracoscopy and thoracotomy. So the American Society of Clinical Oncology basically recommends minimizing the number of ports used and allowing those sections where those ports were used to be surgically excised if indicated during surgical resection if performed. And then prophylactic radiation therapy does not reliably reduce the risk of needle tract metastases following biopsy. So this is a paper from the European Respiratory Review in 2022. It evaluated the sensitivity and complications of thoracentesis and thoracoscopy as a meta-analysis in the diagnostic workup of various different types of cancers. I want to bring your attention here where I highlighted in mesothelioma, both on top in thoracentesis and lower in thoracoscopy. And you can see that under thoracentesis section, there were 8 studies which were analyzed, and they displayed a pooled sensitivity of approximately 45%, whereas in thoracoscopy, pooled analysis, it displayed a sensitivity of 91.5%, which is significantly higher on thoracoscopy than it is on thoracentesis. This slide is just to indicate that mesothelioma has its own TMN staging, and if your patient has been diagnosed with mesothelioma, then you have to refer to its unique TMN staging criteria in order to determine what stage they're at. Here's their prognosis, or a slide regarding prognosis of patients with malignant mesothelioma. It was reported that median survival rates of mesothelioma range from 9 to 18 months from the time of diagnosis, and fewer than 5% of patients survive more than 5 years. So quite a drastic diagnosis. Performance status and histological subtypes are the most consistent prognosticators. And as you can see on this Kaplan-Meier curve, the majority of patients will unfortunately have high rates of mortality within the first 12 months, even after diagnosis. Here's the Burns et al. Prognostic classification model, and this is a classification model which has been verified, and it uses factors like weight loss, ECOG score, hemoglobin, albumin, and histological subtypes to group patients based on their prognostication classification, with groups 1 through 4, group 4 being the most severe prognosis of 7.4 months on average, or group 1, which has a better prognosis but still highly limited at 34 months. And the strongest predictive variable in this prognostication model is weight loss. So approach to treatment, unfortunately for malignant mesothelioma, there is no cure. Approaches to treatment include surgical, immunotherapy, chemotherapy, radiation therapy, and palliative therapy. In terms of surgical approach to therapy, again, there's no proven role for radical surgical resection, though it is still practiced. And there are 3 primary surgical techniques used. There's pleurectomy and decortication, with the goal of minimizing the amount of tumor present in the body. thoracoscopy with pleurodesis, and extrapleural pneumonectomy. And here I have a picture of an extrapleural pneumonectomy, which is a severe and very invasive surgery, which involves the removal of the mesothelioma itself, but basically the entire lung on one side of the chest cavity, as well as the pericardium and a piece of the diaphragm. Obviously, this surgical approach leads patients to have a significantly high rate of morbidity after the fact. In terms of chemotherapy and immunotherapy, immunotherapy is our first-line approach with ipilimumab and nivolumab. Immunotherapy is being the first-line treatment, and this is offered for both patients who have been diagnosed with epithelioid or non-epithelioid subtypes, again, sarcomatoid or biphasic. And chemotherapy, pembrolizumab and pemetrexed, with a platinum-based chemotherapy, is also available as a first-line systemic treatment option for patients who have been diagnosed with a histopathological subtype of epithelioid or non-epithelioid. And chemotherapy is reserved only for patients who have epithelioid histological subtype, and we use pemetrexed plus platinum-based chemotherapy with or without bevacizumab. In terms of radiation therapy or radiotherapy, has not been proven to be beneficial as a therapy and may cause pneumotoxicity, and is used predominantly in the hemithoracic radiotherapy preceding or succeeding extrapleural pneumonectomy, after subsequent to decortication of pleurectomy, or as a palliative approach to help mitigate local symptoms. Back to our patient. So our patient was diagnosed with epithelioid type malignant mesothelioma. She's being followed in our center by our oncological team, and she's currently stage 3 with no signs of metastases beyond the thoracic region. So she was initially treated with immunotherapy with ipilimumab and nivolumab, but it continued to progress, and this is what we're going to see here. You can see that she's got significant tumor burden on her right lung, around her right lung. And at that point, because she was having poor clinical response and she was having significant side effects from the therapy, she was started on chemoimmunotherapy with pemetrexed and cisplatin. And here you can see that she's had a good clinical and radiographic response with decreased tumor burden compared to what she previously had, especially on this CT, which was taken 3 months prior. So take-home points for this talk: suspect mesothelioma in the appropriate patient, even in the absence of known asbestos exposure history. Our patient, up to 20% of cases report no identifiable exposure. Cytology has limited sensitivity for diagnosing malignant pleural mesothelioma, especially with repeated thoracentesis. Thoracoscopy provides superior diagnostic yield, more than 90%, and should be considered when cytology is non-diagnostic, but clinical suspicion remains high. And serum and pleural fluid mesothelin may support diagnosis, but poor sensitivity limits its utility in early disease. These are my references and my, thank you, my end slide.
Excellent. Excellent, Josh, and wonderful presentation. You nailed it. And I love this cartoon at the end that you pulled up. I have a couple of questions that are popping up here. And
Sure.
can I ask you a question that's from the audience here?
Of course.
It says, why is cytology insufficient in many cases of suspected malignant pleural mesothelioma? And how does medical thoracoscopy improve diagnostic yield?
Yeah, absolutely. Great question. So we basically discussed that cytology from thoracentesis has poor sensitivity. And that's for various reasons, especially in early disease or an epithelioid type disease. There might be a poor exfoliative process, which is to say that the mesothelioma might have poor shedding of cells into the pleural fluid. And so the thoracentesis may not actually be a good diagnostic medium to evaluate those cytological samples. Also, the reactive epithelial cells can confound diagnostic workup because they can be mistaken for neoplastic processes, and so it leads to some complications in the diagnostic workup. Whereas in thoracoscopy, you're able to basically have direct visualization of the pleura. You see the sample, you see the pleural plaque or the pleural thickening. You're able to remove it under direct visualization and send that sample to path lab, and then you're able to basically have much greater confidence in your sampling and get a response from the pathology lab as we saw earlier, based on the meta-analysis, it basically has a 91.5% sensitivity.
Good. So I have another question here that just popped up saying, what role does mesothelin play in the diagnosis of mesothelioma? And what are its limitations? It's a good question, and not many people know that mesothelin is the only FDA-approved biomarker for this. So if you can talk a little bit about it.
Sure. Yeah, that's a great question. So mesothelin, like we talked about before, is the only FDA-approved biomarker, and it is a glycoprotein found overexpressed in mesothelioma. It's useful because it has a high specificity. So if it is found to be positive, it gives you a good indication that you're on the right diagnostic path. But if it's negative, because it's got a relatively meager sensitivity, it may not provide you with a good indication of whether you do or do not have mesothelioma. And yeah, I think that's especially true in
the take-home point here is the sensitivity is poor for mesothelin.
Yes,
correct.
Poor sensitivity, especially in early stage disease.
True. And then I have one more question that popped up here is, given the universally fatal nature of the of MPM, how do current therapeutic strategies differ based on the histological subtype? And what implications does this have for clinical decision making?
Yeah, great questions. So as I discussed earlier, we have three histological subtypes. We have epithelioid, sarcomatoid, and biphasic. And the sarcomatoid and biphasic have a worse outcome, worse prognosis than epithelioid. Epithelioid also responds better to treatment overall. And so I talked about immunotherapy and chemoimmunotherapy, which are both available for the epithelioid and non-epithelioid subtypes. However, chemotherapy on its own is available only for the epithelioid subtype. And so in terms of which systemic treatments are available, and also if you want to get into discussion of goals of care with the patient, the histological subtype plays a large role in both prognosis and response to treatment.
And that's the key, what you just said, that histological classification actually guides your systemic treatment selection. And that's important to know. Correct.
Absolutely.
So I think that's all I have for now. I think it was a wonderful talk, well covered, of a very important topic. You don't see this often, but when we do see this, it's a pretty great prognosis, and diagnosis needs to be made quick. So well done, Josh. And I want to thank you on behalf of the SAB for doing this Fellows Corner. I'm very proud of my fellows every time they come up here and do a unique case presentation. And for the audience, until we meet, of course, thank you. And for the audience, until we meet again, take care.
Take care.